Next topic we'll go over is IPF and progressive pulmonary fibrosis. We'll go over the key trials on high-res CT, the diagnosis of IPF. We'll go over the Panther IPF, Ascend, Impulsus, Inbold, and the Fibroneer trials without further ado. So the first practice-changing article in 2006, Ragu et al., basically in the American Journal of Respiratory Critical Care Medicine, high-res CT criteria for UIP, the UIP pattern specificity. That would be like honeycombing is definite UIP as opposed to probable UIP, indeterminate for UIP. That is the key article in 2006. 2007, Collard et al., acute exacerbations of IPF, also in the Blue Journal, in-hospital mortality, 50 to 80%, median survival after an acute exacerbation is only 3 to 4 months. Sudden respiratory worsening, new bilateral ground glass opacities. It identified IPF as a disease with catastrophic inflection points. The third trials to know are the clinical practice guidelines, most recent 2022, defined progressive pulmonary fibrosis greater than 2 symptoms, physiologic or radiographic pattern within 1 year. Of course, we use the DLCO and the FVC decrease after over 1 year. Validated UIP pattern as a prognostically dominant across the ILDs. A codified phenotype-based treatment. PPF is not necessarily a diagnosis, but it is actionable. The next 3 trials to discuss are a couple, they're actually old, over 10 years old. Gap index, gender, age, and forced vital capacity, DLCO, 3-year mortality. If you gap score, gap is 1, is 16%, gap 2, 42%, gap 3, 77%. Simple bedside prognostication still used in clinics and transplant referral. The Ragu trial 2012, the Panther IPF, New England Journal of Medicine, prednisone, azathioprine, and NAC. Mortality was worse with prednisone, azathioprine, and NAC. Hospitalization was also increased. The trial stopped early for harm. Why it matters, ended routine immunosuppression in IPF. The next study, King et al., 2014, Ascend, pirfenidone, New England Journal of Medicine. The number is 555 patients. IPF patients' primary outcome is forced vital capacity, decline greater than 10%, or death at 52 weeks. And the key data showed that the relative risk reduction is 48%, and it mattered because it's the first therapy to modify IPF in natural history. So that is Ascend should be synonymous with pirfenidone, and it decreased the forced vital capacity decline in 1 year. And the key trial of nintedanib, this would be the Impulsus 1 and 2, showing that nintedanib actually decreased in IPF the rate of decline of forced vital capacity by half. The placebo was 223, and the nintedanib group was 114. Acute exacerbations down, established antifibrotic therapy as standard of care. And then the Inbuild trial by Flaherty in 2019, 663 non-IPF fibrosing ILD patients, progressive pulmonary fibrosis. Nintedanib also halved the decline in forced vital capacity. Benefit is seen in both UIP and non-UIP, proved that progressive fibrosis is treatable. The final 2 trials here are the nerandomilast and IPF, Fibroneer IPF, New England Journal of Medicine 2025, published at the same time as the nerandomilast and PPF. So this is phosphodiesterase 4B inhibition, new antifibrotic class, 1,170 patients with IPF, annual forced vital capacity decline, and the placebo is 183 versus only 115 in the 18 milligram dose, a 38% relative reduction. Safety showed that the adverse events were similar to placebo. It's the first new mechanism approved since 2014. And then the PPF trial, underlying ILDs from HP or connective tissue disease, placebo 116 cc drop, and nerandomilast only 99, 40% relative reduction. Background therapy was also allowed. It confirmed PPF as a drug-responsive phenotype and not simply a diagnosis. So in short, we know now a little bit about high-res CT criteria. We know that an acute exacerbation is a signal for worsening mortality as well as survival long-term after hospital discharge. We know the criteria for PPF, where it comes from. We know a little bit about gap index. We know about pirfenidone. We know the non-utility of azathioprine and NAC for the Panther IPF, Impulsus trial and Inbold for nintedanib, and the Ascend trial, pirfenidone. And then we know about nerandomilast and the Fibroneer trials, basically the new antifibrotic era. And we should understand the forced vital capacity decline. And that's where we're at.